Yeah, so we can start with our the experts will be joining in a few while, and at least just wait for a few minutes, 2 to 3 minutes, so that Dr. Anand Keshwan can join.
Okay, ma'am. Okay.
So I think we can start, and me and Yogesh sir will start the session, and the experts will join, as Baldev sir is not there today. Okay, you can start.
Thank you so much. With all your due permission, beginning with the session. Good evening, everyone. I am Batul, the assigned moderator for today's session from ClearNet, and I would like to take a minute to introduce our platform ClearNet to everyone present here with us today. ClearNet is India's one of the largest digital live streaming platform where doctors generate their medical content. I would like to welcome all the panelists and the speaker doctors who are present here with us today for the AOPG academic program that is being conducted on an every month basis. The topic for today's discussion is case discussion on the nervous system. Team Clearnet is happy and proud to be the digital partner for this webinar. Please have a glimpse on the video that is going to be played. Now, without any further delay, I would like to hand over the session to Dr. Nehal Patel, ma'am. Ma'am, over to you. You can proceed from here.
Yes, so I welcome you all for this AOPG initiative, e-Gurukul, as a PG clinic. As we all know, it's a very successful program of AOP Gujarat, and we thank Dr. Rakesh Desai, President AOP Gujarat, and Dr. Kirit Sisodia, Secretary AOP Gujarat, for the constant support. We also thank Dr. Yogesh Parikh sir and Dr. Baldev Prajapati sir. Baldev Prajapati sir will not be there today because of some unavoidable circumstances. I myself and Dr. Prashant Karya, as a project coordinator, we welcome you all. In today's session, we have a guest presentation discussion on central nervous system. Our presenter is Dr. Maulik Patel, and he is a third-year resident at BJ Medical College, Ahmedabad. And his mentor is Dr. Dhara Gosai. She is an assistant professor at BJ Medical College. We also have as an expert Dr. Anand Keshwan. Sir is a very well-known faculty, and everybody knows sir very well. He's an additional professor of pediatrics at GMC Thrissur. He's IAP National Vice President in 2020 and past National President and Secretary of IAP Neurology Chapter. He is Editor-in-Chief in Indian Journal of Trauma. Sir has many more achievements on his name, and this time with the ID chapter, he was elected unanimously. So we welcome sir. We are very much Glad to have you. And we also have Dr. Anand Iyer from our own city, Ahmedabad. And he is a practicing pediatric neurologist since almost 15 years. So, and we also have his constant guidance at our institute. So we welcome Dr. Anand Iyer, sir. Now, I hand over this for a few words from Dr. Sir is not okay. Dr. Yogesh Parikh sir is there. So, sir, please a few words.
Yeah. Thank you, madam. Congratulations, first of Dr. Maulik to accept this challenge to present the case on the AOPG e-Gurukul platform. And we welcome Dr. Anand here and Dr. Anand Keshwan. Dr. Anand Keshwan has problem with the some joining in the link. So please, any person, Batul or someone can help to Dr. Anand Keshwan to join. And thank you very much, Dr. Nihal Madam, for this wonderful program. And let us start the program. Meanwhile, we can help to join the Dr. Anand Keshwan.
Yes,
thank
sir.
you, madam.
So, okay, so Maulik, all the best. And may today's session give you more confidence on further sessions. So all the best, and you can share your PPT.
Thank you, ma'am. Thank you so much. Today's session, PG Clinic. I am Dr. Maulik Patel, third year resident at BJ Medical College. My case is on CNS. Patient information: 1 year, 2-month-old male child, first by order, born out of non-contiguous marriage, belonging to lower socioeconomic class, according to modified Kupuswamy classification, and residing at Kadi, Mehsana. Presented to us civil hospital with chief complaint of fever since 3 days, vomiting since 3 days, and convulsion since 1 day, and altered sensorium since 1 day. Patient having fever, acute in onset for 3 days, low grade in nature, intermittent 2 to 3 episodes per day, and relieved with medication, and non-progressive. Vomiting was acute in onset 4 to 6 episodes per day, immediately after feeding, and containing food material, not containing bilious particle, blood, or non-projectile in nature, without nocturnal variation since last 3 days. Convulsion was 10 to 12 times per day, lasting for 2 to 3 minutes each episode, in form of tightening of forelimb and uprolling of eyeball, not associated with frothing from mouth or spontaneous urination or defecation. And patient was not gaining consciousness in between convulsion. And patient having complaint of altered sensorium since 1 day. And negative history: patient having no complaint of rash or increased frequency of stool, ear discharge, head injury, bleeding from any side, or dog bite, or no history of any recent vaccination, and no complaint of weight loss, cough, difficulty in feeding, or decrease the limb movement. In 1 month back, patient having similar episode of left-sided focal convulsion. 2 to 3 episode was there in form of left upper and lower limb, lasting for 1 to 2 minutes, resolved by itself and associated with a low-grade sudden onset fever. Thereafter, patient having frequent episode of low-grade fever. For that, they have taken OPD-based treatment, but no investigation was done or no any medication they were on. In family history, father was 26-year-old, 12th pass and labor worker at construction site. Mother was also 24-year, uneducated, and working at similar construction site. Having no history of Cox contact is there, or no any significant family history. Patient was born at Kadi, government hospital, full-term, vaginally delivered, 2.6 kg, appropriate for gestational, and cried soon after birth. And no history of phototherapy was given, or no need for
analysis. Maulik, 1 minute. We are not able to see your PPT. It's not shared.
Yes, ma'am. Now is there visible?
No, still PPT is not visible. So can we do, Batul, can you share?
Just give me a minute, ma'am. I'm checking from my end.
Yeah.
Dr. Maulik, your PPT is visible now.
Yes, now it is visible and it is
Yes.
full screen also. Yes, so go to the first slide. No, go to the first slide. Yes, patient information. Yes, yes, yes. Now, okay, you can start now.
Yes, ma'am. My patient was 1 year, 2 month old male child, born first by order, born out of non-consanguineous marriage, belonging to lower socio-economic class, according to modified Kuppuswamy classification, and residing at Kadi from Mehsana. Patient presented with a chief complaint of fever since 3 days, vomiting since 3 days, convulsion since 1 day, and altered sensorium since 1 day. Patient having fever acute in onset and low grade for 3 days, intermittent 2 to 3 episodes per day was there and relieved on medication, non-progressive in nature. Vomiting was acute in onset, 4 to 6 episodes per day immediately after feeding and containing food material, non-bilious, non-bloody and non-projectile in nature without any nocturnal variation. Convulsion 10 to 12 times per day was there, lasting for 2 to 3 minutes each episode in form of tightening of all forelimbs and uprolling of eyeball, not associated with closing from mouth or any spontaneous urination or defecation, and patient not gaining consciousness in between convulsion and complain of altered sensorium since 1 day. In negative history, patient having no complaint of recent rash or increased frequency of stool, ear discharge, head injury, bleeding from any side, or any dog bite. No history of recent vaccination or weight loss, chronic cough, difficulty in feeding, or decreased the limb movement. In past history, 1 month back, there is history of left-sided focal convulsion. 2 to 3 episode was there in form of left upper and lower limb was involved. 1 to 2 minutes they were lasted and resolved by itself and associated with low-grade fever and sudden onset of fever. And thereafter, patient having frequent episode of low-grade fever. And for that, they have taken OPD-based medication, but no investigation was done or no any medication they were brought. In family, father is 26-year-old, 12 pass and labor worker at construction site. Mother is 24-year-old, uneducated and labor worker at same construction site. No history of Fox contacts or no any significant family history. Patient was born at Government Hospital, Kadi, full-term, vaginally delivered, 2.6 kg, appropriate for gestational age and cried soon after birth. Having no history of phototherapy or no history of NICU admission. Mother has taken routine antenatal care and routine ultrasound done 3 times. Mother has taken supplements and TT injection was there. Patient was given birth vaccine only and BCG scar was absent. In diet history, patient was fully breastfed till 6 months of age. Then they have started complementary diet along with breastfeeding in form of biscuits, sira, and ragi. Diet is deficient in 120 kilocalorie and 2 gram protein. Patient developmental history, pre-illness patient development quotient was 90%. In gross motor, he has achieved a rolling over at 5 months, supine to prone first, and then prone to supine. Sitting, he has achieved at 6 months of age, sitting without support achieved at 8 months of age. And he is able to stand with holding furniture at 9 months, and now he is able to stand independently and walking holding furniture. In fine motor, patient is bidextrous weak, achieved at 5 months, unit stress at 6 months, and he is able to feed himself with cup but with spillage, and mature pincer graph is achieved, but casting was not achieved. Patient is able to speak bisyllables, Baba and Mama, and socially patient respond when called by name. Waving was also present. On examination, patient
So,
was
Just a
hello.
minute. Sure.
So we
Stop.
have
Yeah.
to stop here. So can you briefly describe the history again? Because I a little bit late. I sorry because this connection problem. And Nehal madam and Yogesh sir, with your permission, I'm asking question. So can
Yes,
you
yes.
brief? Yeah, can you brief?
Sir, welcome once again. And
Yeah,
we are very,
because,
very fortunate to have you, sir. So, yes, he will summarize the history again for you.
because
And it's all yours, sir. You and we have Dr. Anand Iyer also here with us to help as an second expert. So you both can ask him any questions at any point of time, sir. Please.
So you have to. There are 3 phases of your clinical history. This first, immediately after your complete history, you have to present, summarize your history. Then after examination, you have to summarize. You have to see what is your professional diagnosis. Then finally, we have lab test and the final conclusion. So now first phase is over. But there are so many lacunae in the history. But you can briefly tell your history like that. Okay. I don't want a complete history. You can briefly. So Maulik, just you have to summarize the first part of the history only. Maybe Maulik lost the connection. Yeah. The art and science of summarizing a history is very important. So nowadays, examiners also lazy and they are looking at the computer and mobile. So they will ask, what is summary of a history? You should know how to sum up a history. Okay.
a patient was 1 year, 2-month-old male child born out of non-consanguineous marriage, presented to our hospital with complaint of fever since 3 days, vomiting since 3 days, and convulsion and altered sensorium since 1 day. And with a past history of 1 month ago, similar with fever, left-sided focal convulsion was there, and no other significant past history of admission and is there. No history of cox contact was there, and no history of convulsion, afebrile or febrile was there in past. Otherwise, a convulsion in form of patient having tonic posturing of all four limb 10 to 12 times per day, each was lasting for 2 to 3 minutes. And then
initially it was focal and once in a while, but now we got a more and more frequent conversion and it's generally seizure, but I don't understand. Any history of status epilepsy?
No child not having epilepsy in past.
Seizure is there, now there is a seizure. Any status epilepsy history there? No. Only brief episode of conversion.
Yes, sir.
Yeah, okay. Okay, then you can go on. So when you are presenting a case of history of a nervous system, you have to give a brief detail. Then you have to say that now child got seizure, then child got some altered sensorium. So you have to go. What are the any history of trauma? Dog bite, something you mentioned. Any history of infection, because child got some prolonged fever and some non-specific fever and 1 month back. It is true. Then what you have to mention the exam wise the clinical findings. The child got any altered sensorium, seizure you already mentioned it. Then you have to mention the cranial nerve involvement, any form of cranial nerve involvement. There is no history suggestive of any of the cranial nerve involvement here itself. Then you have to mention about any history suggestive of motor system involvement. Weakness of one limb, other limb, paraplegia, hemiplegia. So, when you are presenting higher function cranial nerves, motor system sensing in that order, so you have to mention your history also like that. So there is no history of altered sensorium, history of seizure was there, any history of any language in memory, something like that. One thing that is not important. Then you have to mention any history suggestive of cranial involvement.
You have to ask leading question to the parents. Is there suggestive any cranial involvement there? Any history suggestive of cranial involvement there?
No, they haven't noticed any cranial nerve involvement like
So how will you ask?
paralysis.
How will you ask for first to last cranial involvement? How will you ask? Major cranial nerves.
Any
For
deviation,
example, second, third, fourth, sixth. How will you ask?
any deviation of eyes,
Oh.
patient is not able to move his eyes properly, or the patient is able to suck or feed properly, and no any facial paralysis or asymmetry is noted or there.
In this case, defective vision very important here. Any visual disturbance, it is very important. Sir. Similarly, seven it is important. So, for example, if it's a tuberculosis, which are the cranial not involved? Which are the cranials not involved by tuberculosis?
Yes, sir.
Which are cranial, which is commonest now involved?
Commonest
Cranial involved.
sixth nerve is involved. Common.
Sixth and optic nerve also common. First and fifth is not usually involved. First and fifth is not commonly involved. So any motor system by when the child is moving all four limbs, child is moving one part of the body, child is moving all both the lower limb, something like that. No. That also you have to mention in the history itself. You have to mention the history itself. So we'll get a rough idea what you are going to deal with. Okay, then.
Yes.
Then wonderfully you mentioned you mixed here antenatal, natal, postnatal history. Birth history it is there. In a nerve system case, antenatal, natal, postnatal history is very, very important. Why you omitted that one? So what are the neurological implications, importance of antenatal, natal and the postnatal history? What are the important aspects?
In antenatal period, mother have any infection was there or any insult was noted is there in antenatal period. Mother in natal period, patient having history of asphyxia, prolonged labor was there or not?
No, you are not going to kick. What is importance of UTI in a case of a neurological impairment history? UTI. What is history of a drug intake? What's the importance of maternal illness in a neurological impaired child? So all this first trimester, second trimester, because that is very, very important here. Even though the child present here until late, but it's a neurological disease. So up to 2 years, major development will occur. So you have to rightly maybe that history is missing, totally missing. So you not mention about any kicking here, second trimester. Any vaccination not mentioned here. Third trimester again not mentioned. So that is a very, I think you have to mention about detailed first trimester, second trimester. Can you say some drugs producing neurological illness? Mother taken some illness, some drugs.
Valproate is there. It can lead to neurological deficit is there. If phenytoin is there, there is cause neurological damages. Other radiation exposure
taken by the mother. Any illness by the mother? Which illness? Any intrauterine infection you have mentioned?
Yes, torch infection.
Yeah, diabetes you have to mention. What about diabetes? What will produce neurological problem? Diabetes of the mother.
Diabetes.
How it will affect the baby?
Diabetes. It can be IUGR baby, large for gestational age baby can be there. Patient having hypoglycemic episode can be there in postnatal period.
You may get a large baby, difficulty in labor, you may get a hypoglycemic, you may get a mermaid baby, you may get a lower limb. So you may get so many things like that. And hypertension, quickening. What is important quickening? Under condition you get a delayed quickening.
So any other students wants to take this? What is the condition where there is delayed quickening?
Madam, we want 5-6 students and their name.
Yes. So sir, we have many students on the platform.
Maulik Patel. So we want somebody to help him. You can give 3-4 names so that I can add a,
yes,
they can open that video also so that it is easy
so,
for us. That is my method,
yeah,
madam.
So,
sorry.
Yeah, so Dr. Aarti, Dr. Amit, Dr. Dhaval, Dr. Urvi, these are all resident, and Dr. Rohan Modi is senior resident. So you can ask any of them, sir. And any one of you want to take this?
Adi Dhaval.
Arti, Dhaval, Amit, and Urvi.
Urvi. Okay, okay.
Yep.
Well,
Even
actually,
Rohan.
I am from Surat only. I am studying Surat only. I am working Surat only from complete MD also. BJK, I came there several times in BJ Medical College also. During the time of Shashivani madam. Very early 90. Okay, madam. Thank you. So, what are the conditions delayed quickening? Now, Maulik, why you use wonderfully omitted antenatal postnatal history? Okay, you can mention what is the condition delayed quickening?
Yes, sir. Quickening, patient is not intrauterine properly developed. Any insult is there in
Which condition? So it will give some clue to some wonderfully mentioned in our textbook. Quickening means delayed quickening or absent quickening means some muscle disorder and something like that. It's mentioned there.
SMA has spinal muscular.
Okay. And also birth history also wonderfully missing so many things. Can you go for birth history once again? In neurological point of view, I want the main points. Yeah. So what are things you have to mention? Anything you have to mention extra? Any history of cyanosis? When child pass meconium and urine? So phototherapy mentioned there. Can you grade the connectors? How can you grade connectors? Acute and chronic staging. How many stages are there? Aradi or Amit. So all these questions you have to anticipate when you are presenting a neurology case, because most important is antenatal, natal, postnatal, and immediate birth history is very important. Because here, even though the history up to 1 year it is normal, but examiner is very fond of asking such a simple questions. So you should be thorough with what is and cyanosis you not mentioned. Then you want to mention the passage of because hypothyroidism is one common condition which we can treat, means neurological impairment. So such things I think it is better to mention than, and also any neonatal seizure, that's very important. In the seizure, the neonatal period also not mentioned because hypoglycemia, and also you have to mention about definitely what about feeding. Cried immediately after birth, but feeding also very important. Hypoglycemia is one important cause. So what specific findings you'll get in MRI of hypoglycemic child? And directly asking such a question. MRI. Mother is doubtful about some feeding problem. So you are taken MRI. What findings you get?
Gliosis, occipital gliosis most common.
Yeah, it is all the simple question which you are asking. But all these things you have to means feeding problem, any history of jaundice like that you have to mention. Birth history is okay. The next one after birth history. Diabetes is normal, diet is almost normal. Immunization history are not mentioned. That is another important. So what are the vaccine helpful to prevent vaccine help to birth vaccination only BCGs are present. So what are the possibility here? So what is the importance of a BCG vaccine here? Whether it will prevent the tuberculosis TBM, tuberculosis meningitis or not? What is your opinion?
Yes, sir. It can prevent tuberculosis meningitis and disseminated tuberculosis infection.
Serious form of tuberculosis. So how many cases of TBM you are seen without BCG scar? How many cases of TBM you are seen without BCG scar?
10 to 15% we have with absent of BCG scar.
50%.
15.
I think almost all of them have BCG scar. Okay, so here there is no BCG scar, so we will advise them to take one more BCG.
No, sir. No need to. No need to repeat BCG vaccination.
Because there is a BCG, if it is no record there, no scar is there, what will do?
We have to repeat the Montauk's test if we want to confirm that.
According to NTP, Montauk test is now it is banned. No Montauk test, it is banned by old RNDCP, now NTEP. So the question of Montauk test here, the people are right and left is using it, something different. Okay. So if child is not taken BCG, will you advise to give BCG? Child is not taken BCG. A 9-month-old child not taken BCG, will you advise?
Yes, patient is delivered in government hospital is there, and the relatives saying that they are having development of scar over that area of left upper arm.
Yeah, my question is that a child is not taken BCG vaccine, came to you at 9 months of age. Will you give BCG or not? Or what is IAP recommendation? What is a
according to national immunization,
Government of India recommendation?
Up to 1 year of age, we can give BCG vaccination.
What about IAP? IAP means Indian Academy of Pediatrics. I think you are very familiar with the term IAP.
IAP might
something different after 5 years. Okay. And what is importance of immunization history here? What are the importance of immunization history here? Or what are the illness you can prevent with the vaccination? Neurological illness you can prevent. That is a simple question. But here one particular vaccine is very important. So which vaccines are you considered to be very important here?
one is BCG, measles vaccination.
Why measles is important? Why measles is important?
Measles infection, measles encephalopathy is there can be after vaccination.
Yeah,
and
yeah.
Pertussis can also lead to encephalopathy.
Any other reason for measles? Any other measles encephalopathy? What is the late complication of measles? Late complication
can develop.
Yeah. Any other importance of measles here in this patient? Aradi?
Yes, sir.
Any other importance of measles vaccination here? Measles will precipitate tuberculosis meningitis. Not only simple measles, not be measles encephalitis. Measles will precipitate tuberculosis meningitis. And also, of course, your H influenza and pneumococcal meningitis, everything is important. Okay. Next one. Next history, BCG. Then diagnosis is normal. Okay, then family history. What about family history? Even though you drawn a important family history, again in neurological case, what's important for family history? What are the X-linked diseases transmitted in the family? Neurological illness. X-linked. What are the autosomal dominant? So you don't go like that. Now, what about any history of abortion? Any history of early sibling death? Any death in the family? In the case of neurology case, in the case of hematological case, many of the disease, hematology and the neurology, many of the cases are transmitted, hereditary transmission is there. In such cases, you have to take a detailed family history, even though it is not there, means there is no positive family history like that. You have consanguinity, non-consanguinity, age of the father, age of the mother, first child, second child, any abortion, anything like that. In history, because many of the disease, for example, muscle disorder, and also neurodegenerative, neuroregressive disorder, family history is very important. So you have to take a detailed family history. As I already mentioned in a case of neurology case, also in a case of hematological disorder. Because both these there are so many diseases, especially for the exact cases, it is kind of family disease. So all these things you have to keep in mind. Okay. Next one. And also, we want a detailed family socio-economic history here. That is also missing here. Socio-economic history. So, 2-3 important history: antenatal, natal, postnatal, a detailed vaccination history, then a socio-economic status. Just before the general examination, you have to mention whether they are. I mean, see something you mentioned here, but modified Kupusami or some other scale it is there. whether they can afford costly treatment, or there is in some cases we can do some IVIG, something like that. So you have to mention the family issue also. Madam, Nehal madam, any other suggestion? Nehal,
Yes, sir.
madam.
We also ask, let opine Dr. Anand Iyer. Anand sir, you want to ask anything to the student?
No, what are
Thank
the
you.
some X-linked disorder, neurological illness? Because here there's no question of neurodegeneracy. We don't know what is going to, because child development is normal up to 1 year. Up to at the age of 1 year, child started some regression, some form of some conversion. There's some form of not dysmorphology, nothing like that. Child got altered sensorium and some other problem. So you have to keep in mind also, afterwards what is going to happen. If it's some infection, they will improve. If something trauma, they may improve according to severity. And if they are not, more seizure is developing, child is deteriorating, child is developing a regression. In such a case, you have to think about a neuro regression also. So you have to mention, yeah.
Good evening, sir. It's Anand Iyer
Iyer,
here.
sir. Yeah.
Good evening, Anand Keswan, sir. It's a pleasure to see you. Maulik, I just wanted to ask you one question. That in the history you mentioned about the child having seizures when he presented, along with fever and altered sensory. And you mentioned the description as uprolling of eyes with stiffening of the arms or tightening of the arms, all the 4 limbs or something like that. And they lasted for 2 minutes. And this is a history, isn't it? Maybe you have not seen the episodes yourself. So how would you differentiate these, whether these are epileptic seizures from that of these being features of raised intracranial pressure? Are there any salient points in the history taking that you would ask to the parents to, because you know there's a history of previous focal seizure. So, you may have concluded that these were also seizures, but are there any points that you would ask specifically to differentiate epileptic seizures from that of tonic posturing as seen in raised intracranial pressure and in many of the cases of, CNS infections?
In case of a raised ICP, patient having continuous nature of tonic posturing and patient having resistance in a passive movement, like a patient having spasticity can develop there. With epileptic spasm, patient having particular time, patient having episode of tonic posturing or tonic-clonic movement or any type of convulsion, and it relieved after that, but no having altered sensorium after that episode of convulsion. In case of raised ICP, patient having altered sensorium can there.
So this child has got altered sensorium in any case, right? So you're not going to have a particular differentiation factor. So I feel that the tonic posturing and uprolling can also be a feature of raised intracranial pressure. The only thing I would say is for epileptic seizures, there has to be a clear start, mid, and an end point. And particularly in TBM and other encephalitic illness, the seizure type would be focal seizure proceeding to bilateral clonic seizure, not tonic posturing often. But if you have a clear history, and sometimes you have to demonstrate that in front of the parents, you need to act out the seizure so that they can say, yes, this is what happened. So I think that is something to be kept in mind, that if you're not sure, better to just say what you've seen rather than conclude that they were seizures. That's the only point I wanted.
Yes.
Okay, over to you.
So another thing is that other than seizure, what movement we can expect in this case, in a case such a history, what other things you have to ask? It is not always seizure, something else. So what I have to mention here? What are other movements you are expecting?
Patient can having abnormal movement or can be normal movement of body can be also there.
So you have to think about some choreograph movement, some other abnormal restless movement, something like that, hemiparesis, coriform movement, and some abdominal movement also you have to expect here because of chronic illness, chronic nature of illness. So it may be seizure, it may be seizure mimic condition, it may be abnormal movements also. Seizure mimic condition we are not expecting here because child is 1 year old child, birth old, we are not expecting that much. Here, whether it is seizure plus or minus any other abnormal movement also you have to mention here. The type of seizure, because that part I not heard, that is why I not asked question regarding that one. In the beginning I was missing. So seizure part I not touched, that is mistake from my part. So not only seizure, you have to mention the abnormal movement also. Okay. The general examination.
Okay, so we can go ahead in the examination part, sir, now.
Yeah, general examination.
Yeah.
Patient was examined in proper light and exposure after verbal consent of parent. Patient was well built and well nourished, was lying in supine position and decerebrate posture and was tuberous. Temperature was 36.6 degrees Celsius.
So what do you mean decerebrate posture?
Yes.
What is it? Decerebrate posture?
So what do you mean by decerebrate posture? Describe it, Maulik.
Purva or Amit.
Yes. So Amit or Urvi, please describe what is decerebrate posture. Amit, would you like to take? Please unmute yourself. Unmute yourself. Yeah.
In decerebrate posture, patients both upper and lower limbs will be in extended position, and there will be increased tone.
So what does it mean?
Tone will be increased and extended position.
Yeah, that is true. So where is the relation? What is significance? You heard about a decerebrated such posture. So what is important? Where is the level of the lesion, something like that? Okay, then you can leave it here. Okay, next person. Okay, next one. Yeah. Going on. Continue.
Patient temperature was normal, 36.6 degree. Pulse rate was 130 beats per minute by palpatory method, and the respiration rate was 34 per minute. And blood pressure was 122 by 84, suggestive of more than 95th centile for same age and sex.
So what is important here? Pulse, respiration, blood pressure. What is important here?
Patient having a high blood pressure, altered sensorium, and there is signs of raised ICPs there by this meaning.
So what do you call it? Abnormality, BP, respiration, and temperature. Something. So in other words, what is Cushing's triad?
Cushing triads mean abnormal breathing pattern, increased heart rate and blood pressure.
Increasing heart rate.
Triad of raised ICP.
So you get increased heart rate.
No, sir, it's normal in range.
So Maulik, it is increased heart rate or something else?
Raised
ICP? Yes. So you have decrease in heart rate, not increase.
Yes.
That is Cushing triad. You have to mention about. Okay. Respiration, respiratory rate you mentioned. Anything you have to mention in this case?
Breathing pattern
is incomplete in this case. So again, you have to mention regular. What is pattern of respiration? So what are some types of abnormal respiration we get? Increased intratracheal tension, some embedding, coning, something. So what are some? Can you mention some abnormal respiration?
Bitorts breathing can be
there. It is. So you have to mention what type of breathing, whether it is regular and a normal pattern, or whether it is a very tedious means the child is exciting too much, something like that. So you have to mention because in a neurology case. So presentation of neurology case, if your case is a respiratory system, it is something different. If it is a CVS case, something different. But here we are presenting everything in a neurological aspect. So everything you have to give stress to that particular part. That is important. Okay.
Yes.
Next one.
Pallor was present in palpebral conjunctiva and palm. No visible jaundice, cyanosis, clubbing, or edema or lymphadenopathy was there. No facial asymmetry was noted. Patient anterior frontanale was closed and deciduous teeth present, 2 incisor and 1 premolar in upper and lower jaw. Patient in anthropometry.
You have to mention about the general examination here. Anything? What about the examination? Anything you have to mention? So what are the manifesto? Just like general questions. What are the general allergic manifesto of tuberculosis? What are things you get it?
No, sir.
So you have to look for flictin in the eye, flictin in the conjunctivis, flictin you have to look for. You know that one. So what about lymphadenopathy? It's not noted. No, lymphadenopathy it is not there. Any other? What are some skin lesions due to tuberculosis? Any idea?
Neurocutaneous lesion we have to see.
Neurocutaneous lesion, that's something different. But about any stigmata of some tuberculosis, some lesion? What are the skin manifestation?
So anyone else want to take about skin manifestations in tuberculosis?
So just like your neurocutaneous marker, so sometimes the exam may be found of a chronic illness, 1 month history. I don't know what is the case here, but 1 year old child. So we have to think about the pyogenic meningitis, tuberculosis meningitis, any other autoimmune. I don't know what is it, but anyway, you have to ask a common condition in our area, tuberculosis. So we have to think about some tuberculosis general examination also. You have to mention about something like that. Lupus vulgaris, scophlioderma. So you have to mention something skin, okay, normal, and a non-neurocutaneous markers. Okay.
So Maulik, take-home message here is.
Yeah, madam, continue.
Yeah, so take-home message here is you need to mention about what is relevant and not present also. Okay, so lymphadenopathy, scophlioderma, flectanular conjunctivitis, these all are important when you are you're ruling out tuberculosis. That's why.
So we have to give all positive history in support of our diagnosis, and we have to roll out so many history by negative history also. So negative history also very, very important. So the power of negative history you have to understand many times. That is important because I think you have to mention as a for presentation. Okay. And also here, I don't know, some irregularity. You have to head to foot examination, some facial asymmetry, then anterior then some deciduous tooth. I don't know why it is mentioned. So you are in order way, head to foot. You read the patient from head to foot. Everything is written there. So any malnutrition evidence, how is his hair, how is any flectanular conjunctivitis, what about cervix, then you have to neurocutaneous markers, you have to mention. Why teeth came here, why facial asymmetry came here. It is not needed here. Facial asymmetry will come to 7th hour. And teeth, okay. You may mention in the GAT part. Anterior phone, you start from anterior phone. In that way, you have to from head to foot, you have to examine like that. And here, then first facial asymmetry, then anterior phone, then again deciduous tooth. Some not looking good, something like that. So head to foot exercise you have to mention separately, and you have to see all the findings because we are expecting a neurodegenerative disorder, an infection, or autoimmune encephalitis, some other factors like that. So you have to mention that if you can mention facial, you can mention about the core species. In the case of hypothyroidism, mucopolysaccharide, you can mention core species. You can mention facial asymmetry is 7th hour. That we are not supposed to examine here. Madam, I think you agree with me, madam?
Yes, definitely, sir. So there are many things which are needs to be mentioned. Like as we mentioned in the negative history, we need to mention some negative points in examination also, which are leading us to a proper diagnosis. So we have so many things in a differential diagnosis in our mind when the child presents with complaining of tonic posturing, and we don't know whether it is a tonic epilepsy, or it's a tonic conversion, or it's just a sign of raised ICT. So if you examine the fontanelle and it is raised, you have one idea. If you examine the coarse features, if you have mentioned that there is cutaneous markers, then you have other ideas. So you need to rule out and then to reach to a single diagnosis. So always examine everything and mention whichever are there in your differential diagnosis.
Why you mentioned about deciduous tooth present at one? Why you have specifically mentioned that? What is important here? You want to rule out hypothyroidism or something like that. So, what is neurocutaneous marker? Anywhere you mentioned neurocutaneous marker? Not mentioned. So I think you have to include in your history. Okay.
Okay. Anything else? Ayer sir, if you want to ask anything. Anand Ayer sir.
No, I think it's fine. I think we've had a productive discussion, so I'll probably skip for the next one. Yeah.
Yeah. Okay. So go ahead.
Yes.
Anand sir also Anand Ayer. I'm happy. My name.
Yes, sir. So we have both the Anand today in CNS.
Yeah. Okay.
In anthropometry, patient was weight for age was 98%, height was 96% for age, and high weight for height was 98%. Patient was belonging to median to -1 SD of Z score. Sir. Patient having no macro or microcephaly was significant.
So we are skipping mid-arm circumference here because we are pediatrician. Your weight is ready. We are expecting some malnutrition, some cases. So you have to mention mid-arm circumference. You cannot skip like that. That's very important because we are pediatrician. Basically, we are not neurologist, but we are pediatricians. So such things you have to mention. So can you say some cause for the macrocephaly? Large head or Amit, what are the cause for large head? A simple question, you get a simple question. What are the cause for large head? He mentioned this no microcephaly, this no macrocephaly. So you can see.
Hydrocephalus is one of the cause. Any intracranial tumor may be there. Or
you won't get large head. It may produce secondary hydrocephalus if it is before close of antifonal. What do you make hydrocephalus? What do you make hydrocephalus?
yes, sir.
Simple question. We ask very simple question.
What do you mean by hydrocephalus? Sir is asking. What do you mean by hydrocephalus? Define it.
Hydrocephalus is excessive CSF inside the ventricles.
Yeah.
That will lead to hydrocephalus.
The enlargement of the ventricle, simple enlargement of the ventricle need not be always cause large head. Once antifonal is closed, you won't get a large. You may get a hydrocephalus inside, but you won't get a large head. So it is okay, hydrocephalus. So tumor. What other cause for the large head? Common cause in the ward. What we are seeing in the ward.
Yes, any other student? Dhaval, Aarti, you want to take?
Ma'am, any intracranial tumors?
Any other?
Rickets can lead.
Yes.
So tumor won't be large. Tumor.
Achondroplasia may also have.
Yeah. So you have to go from outside to inside. It may be skin and soft tissue. Then bone, achondroplasia, epilepsy, anemia, thalassemia, then subdural space, then brain itself. So what are the cause for the macroencephaly? Brain itself. What are the conditions to get a large brain?
Canavan's disease.
Large brain. What is the condition to produce large brain? or brain mass is
Can I-
large.
Yeah, so Urvi said hydrancephaly. Okay.
Well, large brain is it is not hydrancephaly. You will get a leukodystrophy there, Alexander disease, Kanama disease, you get large brain, Soto syndrome, then mucopolysaccharidosis. All this will get a large brain. So you get a large head. In mucopolysaccharidosis, bone also will be large. So you have to think about all this condition when you are discussing about. And finally, due to dilatation of ventricle itself. So you have to go away outside in or inside out in a systematic manner. So it is very easy to explain what are the cause for large head. Okay, next one. So you have to mention Madame circumference. Even though you are a neurologist, don't forget about our basic pediatrics. Other measurement, I am not saying what about the Kanavati formula, something like that. I am not mentioning. But anyway, it is you have to mention Madame circumference. That is very important here. Okay.
I would like to start with CNS examination first. In higher function, patient was focused
It is not CNS.
decelerate posture.
Only it is not CNS. It is nerve system examination. You are examining both central and peripheral nerve system. So don't give a chance to scratch for examiner. Okay, I know what you mean. The CNS meaning nerve system only. But we are examining. What are the peripheral nerve system we are examining here? What are the peripheral nerve system going to examine? In the case of nerve system examination, what are the peripheral nerve system you are going to examine?
Paresis is there or not? Patient having paresis.
Everything is in central nerve system only because you are tracking pyramidal tract, everything like that. You are looking for peripheral nerve. You are looking for skull and spine. You are looking for so many other signs of meningeal irritation. You are looking for so many things. You are looking for it. So it is you can mention nervous system, not always central nervous system. Okay.
Patient was tuberous in decerebrate posture with Glasgow coma scale of E3, D2, M2. Patient was eye opening on verbal command, moans on pain, and decerebrate posture. Moods, language, memory, speech cannot be assessed. Cranial nerve examination. In positive finding, in cranial nerve 2, patient having vision, visual acuity cannot be checked, but fundus was suggestive of bilateral grade 2 papilloedema and Menas reflex was present. For cranial nerve 3, 4, and 6, eyes was in median, not deviated to any side, pupil was dilated, normal light. And the patient having a fifth nerve, corneal conjunctival reflex was normal, touch sensation over face was present. Facial symmetry was maintained, not face was deviated to any side. Gag reflex was present.
Mogesh, I want Urbi, you mute yourself. So many sounds are coming. Urbi Patel. So I want more details about fifth and seventh nerve examination. It is incomplete here. What are things you look for the fifth nerve?
A muscle of mastication.
Mastication, some motor involvement of the face, but the
only sensory system and the corneal conjunctival even you can mention in the superficial part. So you are not mentioned about any this one here. And what about seventh nerve? So based on SO before, what is a very simple thing. So you have to mention about details about the facial nerve palsy. Because here it is maybe localizing value. What do you mean cross hemi? Why it is important? Why what do you mean cross hemiplegia? Aradi, what is Aradi? What do you mean cross hemiplegia? Or Urvi Patel?
Sarti or Dhaval or Urvi. What is cross hemiplegia?
Why we are stressing on too much on cranial nerves? Why you are stressing too much on cranial nerves here?
Sir, facial nerve involved on the one side and the body parts, hemiparesis on the opposite side. It's called cross hemiplegia.
That is true. So we have to say the site of lesion. We have to localize the lesion. The extent of the lesion we have to know. So just a nasal lobe fold or just a facial, you have to mention upper part of the face, not mentioned at all. Here he mentioned about lower part also. Such things you have to, because this is some cranial nerves commonly involved. So seventh nerve you have to mention complete. So can you go once again complete mention seventh nerve, fifth nerve okay, seventh nerve complete. Seventh nerve complete examination part.
In motor system, patient must.
Seventh nerve complete examination part. This is incomplete from your side. It's a very important crime now, and you can get a case independently. Seventh nerve itself give for examination. The Bell's palsy. So seventh nerve you have to complete it. What are things you have to mention here? What are things we test in case of seventh nerve? It's a simple question. I am sorry, but we have to complete it. Seventh nerve examination. How will you express it?
Lacrimation is there.
No, not first lacrimation. Is some order is there.
Taste sensation.
No, what do you first examine in a case of seventh nerve in an orderly way? You are seeing a patient first time. You are examining. You are standing in front of the patient. What thing you first look for? Lacrimation is first look for. No, it is not. We are not doing like that. Right? So how will you start examination?
Sensory, motor, and then autonomy.
Yeah. Okay. What about the motor?
Supplies the muscle.
Amit, how will you examine seventh nerve?
Sir, I will ask the patient to front and then to close the eyes.
Yeah, that way you have to go. You have to look for the West phenomena. You have to ask to close the eye tightly. Then you have to ask the nasal level forward. Then you have to do the whistling. So all these things you have to mention, because seventh nerve is very important. You can't just skip like that. That is very important here. Okay, then 9th and 10th. What you mentioned? 9th and 10th? 9th and 10th? 8th nerve cannot be assessed. Why 8th nerve cannot be assessed? Why?
Patient is a stuprous.
So you can look for cochlea. Means vestibular cochlea. There are two parts are there. Vestibular cochlea. You have to look for in stem something like that. So it is not always a not good say, not assessed, not able to examine, not able to lecture like that. So I know patient is stuprous in a decervate, decorticated region like that. Okay, gag reflex present, then 10th nerve cannot be assessed. Why? You can just ask any nasal regurgitation. You can ask nasal regurgitation, thing like that. You can ask. Okay. Okay. Carry on. Motor system. So most important part is here motor system. So you want a perfect presentation of motor system here. Okay. So to sum up, what are the positive findings in your case here? In the cranial examination, I think we got only one positive finding. What is it?
Yes, sir.
What is the positive findings regarding cranial nerves here? Your all cranial nerves are normal, except you got one finding. What is it? You only
Papilloedema.
Papilloedema is there. So there are some features of the resting contraction. Papilloedema is there. Optic cutter, not papilloedema or optic atrophy. So in the case of unconscious child, what are things to examine? In the eye. Fundal examination, what are things to look for? A child with developmental delay, neurological patient, what are things you would like to examine in the fundus or in the eye? What are things to look for? What are things to
So,
look
Maulik,
for?
what are the signs you will see in the eyes in any case of unconscious patient? Sir is asking about the eye signs. examination eye signs in
Yeah.
unconscious patient.
In a neurological patient. Not only fundus, but other things also you can mention about. For example, you may get a galactosemia, you may get a cataract, you may get dislocated lens, then you get a cherry spot, then you get a chorioretinitis, then you get a cherry spot. You may get a pigmentation in NCL. So
Even unequal pupils, okay, pupillary reflex, unequal pupils, they are also important.
Important in any conditions. In that way, cranial exercise is important. Fundus exercise is totally different. So you have to keep all these things answers ready. Okay, motor system.
Muscle bulk bilateral was normal. No any wasting was there. Tone in all four limbs was hypertonia and lead pipe rigidity was there. Patient power, sensory system, gait and cerebellar system cannot be assessed. In superficial reflex, plantar
Why
reflex
can't
was
you
bilateral.
just power you can examine to an extent. When the
Yes.
child is
Why?
moving limb,
Yes,
something
why
like
power
that.
is not examined? Power is a thing you can examine up to one extent.
Great, I agree. Cerebral sense also you can examine. What are cerebral sense you can examine here? You can look for nystagmus, hypotonia. So don't say that not examine together. Power, okay,
So,
the child is moving with
so
some.
Aarti, can you take it? How up to which grade of power you can examine in a semi-conscious child?
Ma'am, grade 1 is when there are flickering movements, but child is not able to lift up the limb. Up to grade 1, we can see by examining the child.
Anything grade 2? How many grades are there for power?
Ma'am,
On
You are
painful
muted.
stimulation,
You are
patient
muted.
can.
Yes, Maulik. So up to painful stimulation, if the patient is moving limb against the gravity or with gravity eliminated, up to that you can definitely look for the power. Only the force part is removed. Okay.
That is very important. Second thing is that here we are not testing power only. The child is moving all four limbs or not. So what about motor weakness? That is we are looking for it here. You know, say the child cannot walk like that. This we are not taking like that. So whether his one part is involved, hemiplegia, he got paraplegia, whether he can move like that with the pain, without painful. Sensory system also he can examine whether he can appreciate pain or he's moving the limb against pain, like something like that. So examiner is not very happy with the power, sensory system, gait, cerebral sense cannot be assessed. That is not a good statement. So what are the muscles? You are not assessing the power. What are the muscle groups in the body where you are not assessing the power? What are the muscle groups?
Muscle of hand and sole, palm and sole muscle are not included there. Then diaphragm is also not included in.
Diaphragm is also we cannot do it, but you can see that the muscles of the back and the neck also we are not testing routinely. So we can say to an extent we can do it cerebral sense also like that you can examine it. Okay, then.
Patient bilateral plantar reflex was extensor and corneal, conjunctival, abdominal and cremasteric reflex was present.
Present. Okay.
In deep tendon reflexes, knee jerk was bilaterally exaggerated, ankle was +3, and ankle clonus was present in positive finding.
So according to I don't know why it is in an orderless, colorless way, because a knee jerk first appeared, then ankle close, something a jaw jerk in between, and totally disordered. So everything should be in order. We seniors and also all textbook are describing in a particular fashion. So you are very particular about arranging in a disordered way. So you are giving a chance to us to keep it in a proper way, something like that. Why? Because you have to. So how can you mention it in order? Deep tender reflex.
Yes, so always go from above to downwards. And
Yeah,
why?
that is a custom. Here below is the angle jerk, then above is the, I don't know. So you just mention present in an orderly way. How you present it?
And you have seen for one
First
clonus. Is there any other clonus present in these reflexes?
patellar clonus is can be.
So whether it was present or not?
No, ma'am, was absent one.
Okay, Dr. Dhaval, how do you elicit patellar clonus? Anyone can take method of eliciting patellar clonus?
A patient in a supine posture extended with a knee, and patient patella should be stretched downward and with fold, and look for the contraction of the quadriceps muscle.
Yeah, first you have, yeah, that is right. So you have to first mention jaw jerk. So what is in the front of a jaw jerk? What is in front of jaw jerk?
Fifth now is efferent for the jaw jerk, and fifth now is efferent for the jaw.
No, what is afferent? What is efferent for jaw jerk? Aradi? Jaw jerk. Every first got the afferent and efferent. What about the afferent of jaw jerk and efferent of jaw jerk? Which nerve? I think two simple question.
Fifth now is
Afferent or efferent?
efferent is seventh and efferent is fifth now.
Oh. And you mentioned here, angle jerk, lower limb jerk is exaggerated, 3+1. So according to which system? So how will you get reflection power? Which system you are using here? What is the grading system?
0 to 4 grade is
That
there.
is not ion. What is the name of that system?
No, sorry.
Grading scale. Which grading scale? Dhawan, Amit, Aradi. You heard about MRC? Medical Research Council, something like that. So grading system is like that. So what you want to say that Mauli? So you have to mention first a jaw jerk. Then you have to mention about in that order. So you can do about triceps, then biceps. Then you have to supinate. Then you have to mention about lower limb reflex. And here you mention about only angle consoler and also parallel cones also you have to mention.
Yes.
Okay.
With signs of raised intracranial pressure, patient was McEwan sign, papilloedema was there, high blood pressure, tachycardia, vomiting, altered sensorium is there, and in signs of meningeal irritation, neck rigidity, Cunning's and Bruskinski was present.
No, here also what we used to pattern, what we follow is that motor system, then you have to do a sensory system, then you have to look for the cerebellar signs, then gait. That is a usual pattern. In sense of raised intracranial, McEwan sign won't come here. Papilloma already described. High blood pressure we already mentioned. So there is no separate stage for like that. So when you are thinking there is raised intracranial tension, actually asking you can mention about things. Here, right? If I accept asking, why there is here you are suspecting raised intracranial tension here, you can mention all these things. Here there is no separate step for the neurological examination here, but all these things I have mentioned. So you are getting McEwan sign here. So you are, what is McEwan sign? What's the McEwan sign?
When there is an increased raised pressure due to hydrocephalus, there is fluid accumulated. So then we have tap from skull from one side, and we hear with stethoscope from other side. the sound of this tap is directly transmitted to the stethoscope. So we have get exaggerated sound of this tapping.
It is a crackpot sign. When the switches are separate, here your antiphonal is closed, then switches are closed, then you are very unlikely to get it. If it's okay, because one day cerebral edema, child has got antiphonal closed, and then you got one day cerebral edema, it won't open like that, it won't, and you won't get that much of this one. Okay, that's a crackpot sign. And other things we want to discuss because there is no separation for ischemic concern. And the signs of meningeal irritation you mentioned. So neck rigidity, next and Buddhist scan. So what are the conditions you get a neck rigidity? So because you are examining so many, why you are examining so many things, neck rigidity, connects and Buddhist skin, and why you are examining all these things? What are the cause for neck rigidity? Why can't you rely on neck rigidity alone?
In case of meningitis, there is neck rigidity. In case of meningismus, also there is neck rigidity.
So you get so many conditions, false positive neck rigidity. And what are the conditions? Meningitis, you get the absence of neck rigidity. You won't get the neck rigidity even though it is a case of meningitis. What are the conditions? So first thing you mentioned, you got neck rigidity in the absence of meningitis, intracranial causes, extracranial causes. You have to divide like that. So intracranial causes and extracranial causes. Intracranial may be subarachnoid hemorrhage, posterior fossa trauma, benign intracranial and so many causes are there. Extracranial may be bone, muscle, tonsils, lymphadenitis, so many things are there. Anyway, when you are saying you have to say classify them and describe them in a systematic manner. That may be good. And second thing is that so what are the condition? Already you will get a child go to meningitis, but there is no neck signs. This is a common condition in the ward. This is a very common condition in the ward. So you may miss meningitis because child got meningitis, but when you examine, there are so many signs. Purvi, Amit, anybody can answer. All these are simple questions. What are the commonest condition? Commonest condition in the ward, the general ward. You may get a child with a meningitis, but there is no neck sign. Not neck sign, not other sign. Infancy below 1 year. Infancy. You cannot only below 1 year. Newborn, you won't get neck signs. In a partially treated meningitis, you won't get it. Severely immunosuppressor and a malnutrition, you won't get neck stiffness. These are usual background questions. So you have to think about all this in mind. Okay, next it is there. Here already everything is positive. Do you heard about Dhoni sign? Something? What are other signs you can look for the many signs of meningeal irritation? Any other signs? Anybody? They are not naming anybody because the end of the discussion. Any other signs? Your SL, Lasagos sign, tripod sign, your simple photophobia, all are signs of meningeal irritation. Okay, what is Johnny sign? So you can demonstrate neck stiffness in the sitting position. So usually we keep the patient lying down and we will flex the head. What we are doing here, we are stretching the nerve. So when sitting and you are trying to flex the, after sitting, you are trying to ask him to flex the head, then there is a stretching of the both at the hip region and neck region. So it is more sensitive. So you can demonstrate neck stiffness in the sitting position. So means a very early case you can detect it. So once in a while examiner asks, if you can read some neurology textbook, it will be there. Okay. Okay then.
So we have one question also from the other students which are watching. So one person want to know that can you describe a little detail in the course of 1 month from focal seizures to the present episode in the past history, like what happened with, and in form of what was the daily activities of the patient and what about the feeding of the patient.
Patient having there was intermittent low-grade fever was there in patient, but no episode of convulsion was noted in history. And patient having some development regression is also there.
So there is echoing. Amit, please close your mic. I think you both are sitting in the same room. Yes. Yes. Now continue, Maulik.
Intermittent low-grade fever was there during that period, but no repeat episode of convulsion was there, and no having feeding difficulties there, but patient mobility and other domain was almost normal in during that period.
Okay. So we can go ahead in examination, sir.
So you have to mention for completion sake, you can mention about the peripheral thickening, skull and spine is normal. No browio over carotid, something such things. It is a neurology case. The case you can just pass like that, especially skull and spine, you can just mention here. Because you can expect other things, secondaries in the bone, skull, then you can expect any sports spine, something like that. And abdominal shape of the head, everything is you have to keep in mind. So I think once in a while you can mention about this, then you go for other system. Okay.
In respiratory system, patient no having signs of any respiratory.
Just a minute, Maulik. So, yes, sir, you want to ask anything in nervous system before he goes to any other system?
So I think what are the positive findings here? You go to deep into the plus brisk. Child is you mentioned about arterial sensorium. Then you mentioned about cranial involvement in form of papilledema. Motor system, child is moving all four limbs, but power is deep temperature press are exaggerated and a child got activeness. So I think that is almost very clear. So what I think there is any findings here, respiratory system. There is some percussion, bilateral hospital course capitation is there. Some capitation is there. Okay. So what is your final diagnosis? You sum up the history, then you mention your yeah.
Yes, sir. 1 year old male child presented with fever, vomiting, convulsion, and altered sensorium with history of low-grade fever and focal convulsion 1 month ago, with signs of raised ICP and meningeal irritation and bilateral pneumonia in a partially immunized child, sir.
So we are getting bilateral pneumonia. That's a very bad terminology. And how can you say this is bilateral pneumonia with your findings here? So what are findings is getting pneumonia? Is there any here fever is there? Fever is there?
Patient was presented with fever, sir, and
okay.
Course crepitation is there on auscultatory.
And that doesn't mean you got a pneumonia. Pneumonia is to take some bronchial breathing, some percussion abdominal findings. Then only you can say even though whatever it is, then I cannot say like that is a bilateral pneumonia. Some respiratory findings, some lung infection. You can, at least you can mention about what is the respiratory rate here?
34 was there, sir.
Yeah, so how can you say ARI program also? You don't say it is any pneumonia here. So why ARI program is not stressing on fever here? Here you have ARI program not giving any importance to fever. Why? Just because you have mentioned about bilateral pneumonia, some predications there. That is why I am asking. So why ARI program is not addressing anything about fever. What is the ARI program? What are the important parameters?
Yes. So Maulik, can you tell us the findings of pneumonia, no pneumonia, and severe pneumonia as per ARI classification?
Yes, ma'am. If patient having only cough cold with no tachypnea is no pneumonia. If patient having tachypnea,
yeah, that is enough. Why they are not mentioning about fever? Why you are not mentioning about fever in a case of pneumonia? ARI program, why not mentioning about pneumonia? You are saying here child got pneumonia because of the fever. But ARI program not at all mentioning about fever. Why? Some mistake from central government because they are not mentioning anything about fever in case of ARI program. I think question is clear. Only question is clear. Why ARI program not mentioning about the fever in the case of pneumonia? Is there they are mentioning it? ARI program? They are mentioning anything about fever?
Yes. So why the fever is not important in ARI? The central government doesn't thought that fever is that important to took in a diagnosis of pneumonia. That is what sir is asking.
Dawal, I think Dawal. You can help him, Dawal. You can think about it, when you are sitting, you can sit about it. Government about the ARI program. They are saying about pneumonia. No mention about fever at all. We are suspecting pneumonia when there is a high grade fever. Why such things are happening? It is not related to your today's presentation, but once in a while examiner asks such things also, especially in case of high grade fever, pneumonia, suspecting bilateral pneumonia. Then once in a while you think about it. Okay.
In pneumonia, they have included fever with tachypnea.
Fever never, it is not included everywhere, anywhere. Where is fever? You go and read ARI program once again. And the way they are not mentioning about the fever in the, you get my number from Neha madam, so you can call me. Why they are not included?
Yes.
In the case of pneumonia. Okay. So what is your professional diagnosis?
Patient can be case of disseminated pox with tubercular meningeal encephalitis with progressive pulmonary disease, can be case of acute viral encephalitis or pyogenic meningitis.
So you can keep one diagnosis, then you can go. Then I am suspecting this one and this one like that. All diagnosis equally. So here I just says tubercular meningo, tuberculosis meningitis or meningoencephalitis. Why tuberculosis meningitis enough na? Why meningoencephalitis? Pyogenic meningitis, viral encephalitis. When the tuberculosis meningoencephalitis, tuberculosis meningitis will do, or will not do?
Having altered sensorium persistently.
Yeah. We are asking just a question. Some question we are asking to help you also.
Yeah.
So it is not very always not tough question because you cannot get it in tuberculosis meningitis alone. Because how will you grade tuberculosis meningitis? How will you grade?
1, 2, 3, 3 grades are there.
What about your patient? Which grade?
Stage 3 is there, sir.
Grade 3 is there. What about grade 1?
Grade 1 non-specific signs like.
Yeah, so we cannot diagnose tuberculosis meningitis at that stage. So in stage 2 or 3 only we can diagnose it. So stage 2 means there will be seizure, there will be focal deficit. Stage 3 always will be a plus unconsciousness also. This will record. So this always tuberculosis meningitis only. And okay then. So you want to rule out some other investigation, right? You want to do some investigation accordingly. Okay.
Yes. Patient having HB 9.5 with microcytic hypochromic RBCs was there. WBC platelet was normal. ESR was 14, slightly raised, and the renal function test and electrolyte was normal.
Back. Blood urea 4.
Yes, sir.
Blood urea 4, that much of low? I don't know. Not so. And the creatinine also low. And the sodium potassium. What is about sodium potassium here? Just a casual. You have sodium potassium here, and you have not done LFT also. So what is your take on that one? Means you have done sodium potassium, not done LFT. Why LFT is important?
Yes, yeah.
That will come later. What about sodium and potassium?
Sodium is slightly lower side, 135 is.
No, what is important of sodium and potassium? You are doing sodium potassium casually, but any importance here?
Electrolyte imbalance can lead to altered sensorium and convulsion.
Okay, that's one reason. Okay, and in our case, because you don't get electron imbalance like that. One child came to you with the electron, you may get hyponatremia, some specific situation. But in your situation, we'll read from this side to that side. Or patient came with the altered sensorium and some unconscious, and madam told you to tomorrow onwards you repeat the sodium and potassium. What is the reason?
SIADH can develop with raised.
Yeah. That is right. That way we learn. Okay, next one.
Yes. CRP was slightly raised. PT-APT INR was normal. Iron deficiency was there, sir. SGPT, bilirubin was done within normal limits, and HIV was non-reactive, and serum calcium was within normal limits, sir. CSF examination done. Color was clear. Cough base was absent. WBC count were 120 cells per cubic mm. Differential was 60 and 40. Polymorphs and lymphocytes. No RBC was there. Protein was raised 108, and the sugar was slightly lower side, 49.
So you keep the cell there. You keep it there. You keep it there. That's right. So what is the condition you get cobweb? What is important cobweb?
In tuberculosis infection, there can be cobweb is seen.
Why? Now, what are you going to high protein? What are the conditions you get high protein in tuberculosis meningitis?
So you are giving hint to your questions only. Maulik, the question was why the cobweb forms.
Protein is raised and due to inflammatory process.
So how much protein you need to be raised to form a cobweb? It's just a marginally raised protein, or there is some limit where the protein is raised up to that, after that you get cobweb.
Then only you get a cobweb. And another thing is that protein. So what are other conditions with a TBM high protein? Any other particular condition? Any other? In spinal tuberculosis, due to block, spinal block, we will get a high protein. Another condition. What are some other conditions you get? Not this case, high protein in the CSF.
Guillain-Barré syndrome, we can get a high protein.
What is normal protein level in newborn? What's normal protein in the newborn?
50 to 80 mg per DL is that.
That is normal protein for adult, older children. In newborn, it may be still high.
Up to 120 is considered.
Yeah, you may get high protein. That is why you get xanthochromic also. You get a Guillain-Barré syndrome, or you may get some other administrative disproportion. You get spinal block, which you already mentioned. All this you have to keep in mind. So no RBC, sugar, this one, cobweb. Okay, one important test you are not done, but not
pressure.
one.
Opening pressure of CSF.
And that is okay, because every child will cry, and that means you got a low pressure means against spinal block. Usually getting high pressure. What are important? Very important tests you are not done here. And our residents are not doing it proper, doing it also. That is why that is reflecting here. What is it? For example, if a case of you are suspecting one day history with the fever and the headache and a seizure, you are doing NP. What else you want to do? I think madam will agree with me. So what test you do? Important bedside test.
Yes, bedside test.
Our residents are not doing it. And they are sending it to lab.
Sir, the concept of ward laboratory is now going down. That's why.
But you can take the sample to the laboratory and you can do it there. That is true everywhere. It is true. But in our days, we have to do it. And you can take the sample, fresh sample, and you have to take it to there, and you can see stain yourself. Then what test you can do it? I can only give you more clue than this one. Two important tests missing here. What are they? One is gram stain or AFB. Gram stain you have to do, definitely. Because tuberculosis meningitis may present with acute meningitis may present with tuberculosis meningitis. You have to gram stain, and also AFP staining was just a must.
Yes.
So this bedside test every PG student. At least gram stain. So you are getting on the spot. You are getting gram positive. Okay. You are getting on gram positive. Okay. Gram negative basile. Gram negative coco basile. So your diagnosis is very clear. Within 10 minutes, you will get a result.
Yes, sir.
And you are starting with the empirical antibiotic. And also AFB. Here, if I suspect you are a special thing AFB. What are the tests you will do here? Any other test you want to do? Important test. You have to do culture sensitivity test also you have to do. Culture sensitivity, any rapid diagnostic method available, you can do it.
Yes, sir.
What is Pandis test? When I am student in Surat, I used to do Pandis test. What is it? It is not there now. I don't know it is there or not. What is Pandis test? Which reagent you will use? Which reagent you used for Pandis test?
Don't know.
It is a carbonic acid. I think bedside we should do mix CSF and this one, and you will get a clouding, suggestive of a high hemoglobin level. That is all. This is bedside simple test. So many tests are there, but I think which one we used to practice that time just there. Okay, then.
Patient Montauk's test was negative. Gastric aspiration AFP stain was negative. CB-NAT was negative. Blood culture and
ask one question: how many percentage you will get TBM? You will get a mano test positive, gastric aspiration positive, extra-chestic positive, high ESR. Because when you are considering TBM, you are expecting a mano test positive, you are expecting high ESR, you are expecting a gastric aspiration positive, and you are expecting high ESR. But here ESR is wonderfully normal, mano test is negative, and a gastric aspiration negative, and one more test I mentioned somewhere. So, how many percentage? Chest X-ray. The chest X-ray, what is it here? Chest X-ray, can you explain?
Bilateral haziness is there, diffuse, and right upper lobe collapse or consolidation can be appreciated.
So, what is the first impression? It is a expiratory film. It is not a deep inspiratory film. But I agree, because you can take it. It may be expiratory film, not be, it may be a AP film. Most probably it may be AP film, it may be expiratory film. And what are the according to NTEP, I am not using RNTCP, what are the 3 important X-ray features of tuberculosis? 1, 2, 3, they specifically mentioned.
Hilar prominence is mentioned.
Hilar adenopathy, okay.
Hilar lymphadenopathy. Any collapse or consolidation?
No, that they are not mentioning.
Only 3 specific features about tuberculosis. Sir is asking 3 specific features about X-ray findings in tuberculosis.
Hilar lymphadenopathy, calcification.
Calcification, all this is adult. We are discussing small children. And tuberculosis is so prominent in our area. I think in Gujarat still it is prominent. So you should know everything. Tuberculosis or X-ray findings. Here you can see some regulation here, some regulation, something like that here. Right after the board. So what are the findings we get it then? Okay. So we get one is a miliary shadow. Third one is a fibrocoagulation, which is not very common in pediatric age group. So these are things you have to mention like that. Okay, so you got CB-NAT positive here.
Yes, sir. CSF.
Okay. Yeah. CSF CB-NAT positive, very good. So it may be a case of upper lobe collapse. So it may be a case of tuberculosis meningitis. Any other features of tuberculosis meningitis here? Any other? What about scan? You have done any CT scan or MRI scan, something like that?
Yes, sir. MRI was done.
It is coming. Okay. Okay.
MRI suggestive of moderate dilatation of all 4 ventricles with a communicating hydrocephalus and marked patchy abnormal leptomeningeal enhancement with enhancing exudate in basal cistern, mild to moderate periventricular hyperintensity, suggestive of transependymal slippage of CSF and suggestive of Cox etiology.
What is there in Cox etiology here? Why you saying it's Cox etiology?
A basal exudate and leptomeningeal enhancement and hydrocephalus with periventricular seepage is more likely suggestive of Cox etiology.
Maulik, what is the mechanism of communicating hydrocephalus here?
Inflammation in choroid plexus. There is excessive secretion of CSF, and there is
you got some focal seizure here. So how can you explain focal? What are causes of seizure in the case of meningitis, TBM? What are the causes of seizure in a case of TBM, tuberculosis meningitis?
It can be focal seizure initially. GTC convulsion can be there. Raised ICP.
What are causes? What are types? The causes for seizure in the case of meningitis?
Raised ICP, leptomeningeal involvement, meningitis, and vascular endarteritis. Infarct can lead to convulsion.
So here no evidence of infarct.
Yes, sir. No vasculitis changes or infarct.
What other findings will you get? Focal seizure, chaligitis, focal seizure in the case of tuberculosis. They are getting some other findings. What other findings will get here? What other things will get here? You heard about tuberculoma?
Yes, sir.
So here they are not mentioning about tuberculoma is not there. What else you have to give? What are findings suggestive of as a child with unconscious stage? MRI is not advisable. You have to do CT scan. So what are CT scan findings in right intracerebral tension? You want to do LP, but madam told to do you a CT scan. We look for any signs of intracerebral tension. We postpone CT scan. So what are findings you get in right intracerebral tension?
Dilated ventricle can see.
You get just a reverse will get it. Right intracerebral tension acutely. I am not asking hydrocephalus TBM. You go to patient with meningitis. You want the LP. Madam told her don't do the LP now. There will be some problem. So do CT scan. So CT scan showing evidence of intracerebral tension. So what are the findings of right intracerebral tension?
Dilated ventricle, enlarged site of
effacement of ventricle. You get effacement of ventricle. First you will get like that. How will you get a dilatation? Okay, then
Sylvian fissure are enlarged, can be enlarged. Corpus callosum angle should be checked. It decreases when the hydrocephalus is increases as hydrocephalus.
No, your answer is not to my question, and it is very important practical aspects also. So I think you totally confused or you don't answer. It should be thorough with you because a common scenario in our casualty. A child with a seizure, suspected meningitis, we are not in a position to LP. We are planning to do a CT scan urgent because why MRI, not MRI? MRI is time consuming and costly. So you have to advise CT scan. So you have to identify whether the child got it. So you have to go identify that child got signs of intracerebral tension. Okay.
Basal exudate.
Okay. So finally, how do you treat this patient? Yeah, you got a case of hydrocephalus, established case. But what I am asking is that immediate period in a case of just like a bionic meningitis, some suspecting some intracerebral tension, something like that. Here you got any other view? You got any other view? Yeah. You got enlargement of throat when communicating hydrocephalus. No tuberculoma, I am not very because it's a full film. So which is tuberculoma, they suggest anything? Tuberculoma, I think it is not there.
No.
Okay. So as you can give broad guidelines on TBM treatment. I think now there is no confusion. What are other possibility? What other possibility keep in mind, madam? Madam,
Yes,
what is
sir.
time limit, madam?
So
10 minutes
we
more,
need to
yeah.
finish. Yeah, 10 minutes more. We need to
Yeah.
finish by 8.
So, madam, you can ask a question, madam.
Yes, yes. I'm enjoying listening and conversation, but I'm asking in between also. Yes, sir.
So ISR, go on. ISR is there.
Yes.
Because
So
he is a
yeah,
Maulik is but up with my bowling and the batting is very difficult. Okay, broad
Sir, it is a
guidelines.
treat to listen to you.
Yeah. Okay. Treatment part, okay. So, how do you treat?
Patient needed intubation and ventilatory support, and patient was kept NBN. 2 antibiotic was started, and for
Why
NPI.
IV fluid? IV fluid, what is why IV fluid?
During initial period, patient needed stabilization, and
Anything
convulsion was noted.
keep in mind when you are starting IV fluid in this child?
In active convulsion, we have needed to start IV fluid.
No, IV fluid, how will you calculate anything specific here? Again, God mentioned about
80% fluid is
keep in mind CR also here. So when you are giving IV fluid too much, then you are keep in mind.
raised.
So everything is because the answer is like that only. Electrolyte you mentioned, fluid also very important, nutrition also very important. So first supporting measures as you rightly mentioned, that is important. So from basic aspect, we are not going to say about high-fi things. So 80 in this patient, what will be prognosis? We know grade 3 TBM, what will be the prognosis?
Grade 3 morbidity is up to 80% and mortality
and all of them are left with some form of this one. So it is not make a difference. So what we have our supporting measures. So here I mentioned hydrocephalus. So here you know any staging system by CMC Vellore, hydrocephalus staging system of staging based on consciousness and prognostic staging. Stage 1, 2, 3, 4, Glasgow Coma scale.
One staging, the Puru staging is there. Stage 1, they are having only vomiting, headache is there, no focal neurological.
No. Yeah, it is not something different I am asking. That we only mentioned about it. But I am asking about the staging based on the hydrocephalus and the consciousness of the child. It's very important here because child got hydrocephalus. We have to advise them what is the prognosis that stage 1, 2, 3, 4 based on the Glasgow Coma scale.
For stage 1 and 2, Glasgow Coma scale is a 15 only.
Yeah, exactly. So in between, so you have to sometimes the examiner asks us the questions also. Always don't go means like that. This one. Okay, why do IV antibiotic started means that empirically?
Yes, sir, empirical.
So how much steroid you give?
0.15 mg per kg per dose, 8 hourly week.
0.15, not say 0.15.
The exam.
And what are the role of steroid here?
To decrease the inflammation of the meninges and cerebral cortex.
Any other important function? Important other functions? Don't satisfy with a simple use. You should be ready with it. That may be for first year PG, for undergraduate. When you are second year, third year, you increase your scope. You have to mention 3, 4, 5 courses like that. Madam will agree with me. So it should be not like that. So your patient deteriorated after your diagnosis is right, your drug treatment is right. After 24, 40, after 1 week, child deteriorated. So what is your reaction? What's your impression? Your treatment is improper, child is deteriorating, drug resistant. What is it?
Raised intracranial pressure or
everything
therapeutic paradox. Therapeutic paradox can develop.
Yeah. So steroid is useful to prevent the therapeutic paradox also.
Steroid is
not also because intracranial tension will decrease. It will increase the well-being of the patient. It will reduce the aggregation and this one everything will be decreased. Intracranial tension. So everything will be well. So you can expect questions like it. What are types of intracranial tension? What are types of cerebral edema? How will you manage the cerebral edema?
patient started with injection mannitol and 3%
No, again you are wrong. You have to put proper position, IV food, control conversion, control seizure, control fever, minimum handling. Then you have to go in that way. If you are an ICU person, you handle the page, manage the child with here you mentioned about intubation and ABC mentioned. In that case also, if a person who manage a child with intravenous tension, then you can mention all these basic aspects. Madam may be some different opinion because I am an old person like me. It always
No, sir, definitely. We always answer one by
how
one.
you are approaching a patient in the ward, how you are doing it. That is important. You give monitor, you can give or not give. Dexona you can give or not. What other drug you can give? Sodium, Dexona, dexamethasone, monitor. Then what is a new drug will start now? Not new drug.
acetazolamide can be used.
That no any other drug. Patient is shock. Patient is shock. Volume overload is there. What is we can give?
Hypertonic saline can be.
Hypertonic. What is problem with monitor?
In acute renal failure, we cannot give, or in suspected.
Volume overload. Then it is tachyphylaxis. What is tachyphylaxis?
After 72 hours, after prolonged administration, effect of the drug reduces.
So AKT, which AKT will start? AKT. People call me AK, AK sir. So what is AKT? I am fond of AKT. So what about which AKT you want to start? What is the regime? New latest regime?
Isoniazid, rifampicin, ethambutol, and pyrazinamide.
Alternate day, daily. Or any other formula? Your daily or alternate day?
Daily regimen, sir.
Okay. So you are getting interested in what is the advantage of phenytoin in tuberculosis meningitis, TBM? In this patient, not TBM, in this patient. To put it less sedation, and it is to an extent it will prevent SACR also. So phenytoin will produce sedation. So you can prepare anitol. And then finally, on discharge, what advice we give?
Yes, sir.
There's so many questions.
Advices.
I think Madam will discuss everything in the bedside. And there are so many things. Finally, anyway, we want to discharge the patient. What are things we'll ask?
Continuation of the AKT in proper doses and proper duration is to be mentioned. Patient liver function test should be regularly checked, and other supplementation and patient danger signs should be explained for that. And dietary advice should also be.
So you have to advise physiotherapy. You have to do hearing test because you have to by discharging, and after that because all the medical implications there, medical legal implication. So you have to do medical. You have to do this one proper physiotherapy. Then accordingly, you have to advise them according to this one. So I think thank you, madam, very much for the opportunity. And now you can carry on, madam. I just hear Anand sir is here, and madam, I will just hear for another 5 minutes. I stop.
Yeah, thank you so much, sir. Thank you so much. The whole show was handled so nicely. Actually, even Anand sir was telling me that sir is handling the show. So let's listen. It's actually pleasure to listen you.
No, madam, because my language is little bit speed. So madam is helping him by translating it. But our system is that way. So Maulik, you have to present, you have to read some basic clinical methodology book. I am not criticizing you, so you should be very thorough about it. So first 6 months you will be clinical examination everybody, because pneumonia by repetition you can say. What the examination because trigeminal afferent different is trigeminal. Everything you have to, everything is written there. You have to just read the patient. You read the patient. That's why I used to teach my students. Everything is written there. Everything is written there. For no everything is written there. You just read it. We are helping you to read that language to an extent, but you should be practice it. So what we are teaching is bedside clinical medicine. We may be wrong. But MRA, echocardiogram will prove what is final diagnosis. But we also, by proper history and a proper examination, 95% we are right.
Yes.
Yes.
That is why we are giving much importance to your clinical examination, because I asked Yogesh, can you get some summary about the patient, but he told he don't know. So I am also very happy, because without this one also, to an extent, we could reach a safe diagnosis. And of course, there are so many things to discuss about the TBM, other things it is there. But I think that is beyond the scope of, because of lack of time and everything. I think I have done some justice to the topic. And I once again thank the AOC and Madam and your guests. Bye. And Baldev Pradhavati, great teacher, he was not there. He is my close friend. And sorry, let him come. Okay,
Yes,
well, thank you.
so we thank you so much, sir. All the students also, Maulik, great presentation, and we hope you learned so much from sir. Anand sir, for any final words from you. Yes,
No,
sir.
it was a pleasure to join. Thank you for inviting me, and it was really nice listening to Anand Keshwan sir for so long and after such a long time. So thank you, sir, for
So
getting
Ananda,
into
yes, sir,
pulse
where
of
you
this.
working here from? Ananda, yes, sir, you are from South or you are from Tamil Nadu? No.
ഇല്ല
Ananda,
sir,
yes,
എനിക്ക്
sir.
മലയാളം അറിയും, നന്ന അറിയും.
Yes, sir.
I'm from Palakkad,
Yeah,
but I'm
okay.
settled in Ahmedabad.
So we are coming to Ahmedabad, Gandhinagar in February for our
Yes,
national
sir.
conference.
We welcome you all for IPA, and we will be there to host you and to accompany you there. And
Yeah.
for today's session, I thank you very much, Anand sir also, Anand Iyer sir, for accepting my last minute invitation for this session. And thank you so much, Anand Keshwan sir, for being there as an expert and guiding the case throughout. And thank you all the students. Without you people and without Maulik, this session cannot be go ahead. Yeah. And thank you, Dharavel.
Excuse me, ma'am.
Yeah.
I want to specially thank you for giving the opportunity. And I want to thank Anand sir. It was excellent session. And my PGs will get lot of stimulation for reading before their exam. So it was really a very nice. Thank you, sir.
So,
Thanks.
thank you so much, and thank you, Clarinet, for providing this platform. Thank you.
ma'am.
Good
Thank
night,
you.
all.
Okay.
Good
Thank
night.
you.
So, Batul, we can end the session.
Sure, ma'am. Thank you.